I'm on a stage here with a set of all-stars who know vastly more about this topic than I will ever learn. And so I'm very pleased to be here with you guys, and thank you for all the education that you've given me over the time that we've been doing this. And so we'll just begin by, I guess I should say that I approved the Angelman study when I was still at Ionis, and I had a lot of anxiety about doing it. I thought, my goodness, really there's no reason to think we're going to be able to help these kids. We might make them worse. And so even with the Angelman experience that we had at Ionis, I began n-Lorem still with the belief that for most of the neurodevelopmental things, probably the best that we could do would be to stop it getting worse, maybe, if we were lucky. And I'm interested in how you folks are feeling today about what's possible. I understand the challenges of measurement and all that, but really what I'm interested in hearing is, what do you think is possible today? Liz?
Okay. Well, I think we've been almost shocked by the Angelman experience and the relatively quick. I mean, I have videos I could have shown, but there's many of them, and the relatively rapid acquisition of some new things that just is at a rate that Angelman patients don't gain skills. So I think that, and we really did not think that would happen. I thought we were going to have to follow these patients for years. I thought maybe they'll change, maybe they won't. Maybe we actually need to treat them in utero to really get back to the time when you can actually change plasticity. But I think what we've learned from that is that UBE3A, the Angelman gene, is coding for a protein that is probably important for certain neurodevelopmental steps that maybe we can't reverse, but it's also coding, but that protein is also active on a day-to-day basis in synaptic activity, and that is something that can be changed. So I think now we're kind of understanding that we can address these disorders, but we really have to learn to what extent we can address them, and which disorders are addressable and which aren't, because probably there are some that really are not addressable because their function is predominantly developmental or structural, and once you have a certain type of brain, you kind of can't go back. But I think now that we've got measurement tools, and we can see even from the videos of patients that there's an improvement. So I mean, I always thought in my life it would be great if we could do this, but I was not sure we could. And I think now we're learning from multiple disorders that we can actually change things that we thought maybe were unchangeable in the past.
Yeah, sure. Horatio?
I will throw Stan, I think that the title you put for this discussion is perfect. It's redefining what's possible. So I would like to very briefly mention that we are treating the second patient of a disease called familial dysautonomia. Now, this is a rare disease. It's not that rare, like this, like 300 patients. And these people are born, is a neurodevelopmental defect, but also a degenerative defect. So they are born without the ability to feel pain or temperature, and that brings a lot of complications. In addition to that, progressively they lose vision. They are born with almost normal vision. They lose it progressively, and at age 20, they all need devices or are almost legally blind or in their mid-20s. And they have difficulty with coordination that progresses. So when we model the possibility of the ASO that you guys produced for us, we thought that we were going to stop digging, meaning that the vision and the balance were our outcome measures, where we were going to be able to stop. We did not even look at the peripheral nerves. Although the FDA wanted, we thought, well, this has not developed. We shouldn't dream that this will grow again. But we did skin biopsies in the subcutaneous tissue where you can look at the little sensory nerves. And at the beginning, this wasn't even in the protocol because we didn't want to use it as an outcome measure. So at the beginning, before treatment, there were almost no sensory nerves in the skin, which is the usual thing. In 9 months, they're close to normal. Now, you tell me how that's possible. We want to replicate it. We want to make sure that this is true. But if this is really true, the first conclusion is that we don't know anything, right? I think that it's important to realize that we do not know anything, that everything we have learned in school it has to be relearned, that we have to be open to look at outcome measures, and what Dr. Kravis showed also, right? The idea, I'm repeating what she said also, and also what you said, the idea that we are only going to stop worsening. Well, we can do much more than that. Perhaps we can do much more than that. So I leave it. I just want to be surprised every day and continue being surprised with this. Really, and I repeat it, we do not know anything, and that gives us the ability to dream and imagine. And I think that that's the most important lesson that I learned working with you, Stan, and with the n-Lorem team. Yeah. So thank you very much.
That says about everything you can say, really. And I don't know if you guys remember the pictures of the little green things. Those are nerves that shouldn't be there, that were not there and should not be there, and there's no way they should happen, and they are. And okay, it's one patient, it's one set of pictures, and we have to learn more, but the fact that today we have to unlearn everything we were taught is the most important thing I think we could say. And you look at those pictures, I just never dreamt in my life I'd ever see such a thing. It's just mind-blowing. It's just so cool. and we're learning it one patient at a time, not in big trials. In one patient, and it's teaching us things that will matter to patient after patient. And you showed the videos of Connor, Olivia. Connor is the boy that got me into this, and I never thought that he would walk independently. It just never dawned on me. It's just amazing.
It really is amazing, and I think we're just, echoing everybody else. It's just we're kind of at a new frontier and redefining what is possible, and seeing what the changes that we're seeing in these N of 1 pioneer patients, and they're older even, and seeing those kind of developmental changes at that age, 15 years old, speaks to what is possible, or what, beyond what we initially thought. And again, speaks to then, should we be able to, if we can continue this journey and continue to see these kind of changes, and it's really structured in the same framework as standard trials. So but if we continue to see these changes, it really speaks to earlier diagnosis and earlier potential intervention as almost a preventative.
Yeah. So of course we see significant reductions in seizures, and of course he's a little simpler than Liz's patient, because your patient was on high doses of Dilantin and other things. And so how do you sort out how much benefit he's getting because his seizures are no longer doing him harm versus some other resolution of some other situation, or does it really matter?
I think that it speaks to underlying physiology. It's hard to account for every variable, right? But that's where we try to implement rigor into the trial when we can. And so with him having less sodium channel blockade requirement to begin with, that made it a little bit simpler in terms of looking at anti-seizure med, challenges, and looking at how that might potentially interfere with the actual sodium channel. But to that point, we did repeat the same dose without any changes multiple times to see that the same findings were at the same, whether we did it in the first 3 months or the second 3 months. And that was consistent across the board. And so I think that It's hard to really separate out seizures from development, in my eyes, from an epilepsy perspective, and developmental and epileptic encephalopathies, that's under the same umbrella, and whether we want to optimize both, because it goes hand in hand with improvement in cognition.
Yeah. In your SCN2A patient, of course, you had the complication of several anti-sodium channel blockers, and of course, they're associated with significant problems of their own. And so how do we learn how to tell how much is the benefit of getting rid of that toxin, as it were, and how much is getting rid of the seizures, and how much are we doing besides all that?
Well, I think similar to what Olivia said, it's really hard to separate it, because obviously a person that's having 5, 10, whatever number of seizures a day is constantly living with the seizures, and maybe postictal part of the day and having seizures other parts of the day. Once we get to a point where we don't have seizures for a period of several weeks, then I feel like we've got more of a baseline of what the patient can actually do. And so if we can see change during seizure-free periods, that may be change that's independent of seizures, but again, it's really hard to sort out, because we don't know exactly what having all the seizures is doing to the brain. And then you've got the anticonvulsants, which also tend to dampen the brain and make development more problematic. And so we know that the more we can get the patient off the anticonvulsants and the less seizures we have, the higher functioning they're going to be. But whether certain gains, but how I look at it is, we need time without the anticonvulsants and the seizures to really be able to see what the brain can do. And until we can get to that point, it may be hard for us to see exactly what we're doing, to sort of innate developmental ability, if you will. It's very hard to sort out. But hopefully we can gradually work in a direction where we will have those long, 3 weeks, a month periods free of seizures, and then we can kind of have a better idea of what development is doing.
Yeah. And Jen, you're treating as large a group of patients as we have with KIF1A and HNRNP, and of course, I studied HNRNPs when I was a graduate student. They were called heterogeneous nuclear proteins, and nobody believed they existed. It's amusing to hear them taken for granted today. These are all, as I said it yesterday, these are miraculous things we're talking about here, folks. If you think this is just routine, average stuff, then you just haven't lived in the world that I've lived in. This is stuff I never dreamt I'd ever be talking about. Anyway, enough of miracles, I guess. But it's a word I never used, and now I'm overusing it constantly. Jiminy Christmas, I got to stop that. But anyway, Jen, what do you? I mean, if you think about Susanna and KIF1A and all the things that you're seeing, where do we go?
Well, I think your comment earlier about what we learned, you have to take what you learn and put it away. We were trained in adult neurology, right? And what do we know about the brain and what parts of the brain do what, right? It's based on a fully developed human brain, an adult one. And so we know that this strip controls motor, this strip controls sensory. But that's like in a patient who has a stroke, right? Like you injure that area, you have an injury in the fully formed brain. What happens when from birth you're not developing correctly, and then when you try to fix that, the circuits are going to be completely different. Aside from just the natural history, thinking about the way that develops, we're not talking about injury and recovery, we're talking about how does it build the block from the very beginning. And so we have to kind of unlearn what we were taught, because we don't really know what happens to the developing brain. Look at sensory. I mean, my patient's sensory is like a huge component of so many of my patients, and with lots of disorders, there's no really great outcome measure for that. It's very intrusive, it can be quite disruptive, and we don't really know how to address that or measure that, but certainly it's being impacted. So I think we're, like you said, every day comes something new. We have to listen to our patients who are going through this, say, well, what did you see before? What did you see after? I mean, I'm appreciative of n-Lorem and the FDA to saying, yes, you can treat 3 patients at the same time, because I think we really that allows us to kind of see that those domains changing over time.
Yeah, and I think all of you have said in one way or another, we also have to listen to the patient and the family and recognize that there are many, many scales that we don't have, that we have to adjust what we measure on the fly and do what the patient tells us to do, right?
And you know, with sensory, what Jennifer is saying, what we have a very simple way of measure the ability to sense temperature and pain. So you put a probe and the temperature keeps going up, and when the patient detects that it's hot, that's the threshold. And the same when it's cold. So after 10 months, the first 10 months, there was 5 degrees of difference that patients were able to sense earlier. And also the ability to coordinate movement that has to do with peripheral nerves, the proprioception, also improve, and you see it on the videos. Yeah. So things we did not think were going to improve.
Yeah, and you know, what Horatio was talking about was peripheral nerves. We're treating centrally. Correct. That there would be a change in peripheral nerves that we could measure and see is just shocking. Yeah. Maybe I should stop there. Questions from the audience? I don't want to dominate all this.
Hi, my name is Brandon Nixon. I'm curious if you've ever tried to measure the impact and the benefit on the parents in the situation through the clinic. It's a lot of the measures are obviously on the kids, but there's got to be an impact on, sort of peripheral impact on the parents. I'm curious if you've done any of that work.
I think it's a very good point. I mean, we ask all the time, and we try to see how that impacted in the parents. I can only tell you about two parents, well, 4 actually, 2 and 2 of 2 patients, and they're incredibly happy. They think they won the lottery, and the kids, they believe they are cured. I tell them, well, let's wait, but in 24 hours they say, doctor, I'm cured, right? I mean, we have to see, but the impact I've seen on the parents is that they said is in the one patient was the best year that the patient had, that their son had. Let's hope we can reproduce that, right? Like Stan is saying, we're talking about miracles. We wanted more than miracles. We wanted it to be a daily practice, and I hope it's going to be. They're not going to be miracles. They're going to be what we see every day, hopefully.
Yeah, so parents are always happy when their child is doing better, obviously, but you know, how do we quantify their burden, I think, is kind of what you're getting at. So we have quality of life scales in practically in so far all of our N of 1. The quality of life scales, the standardized ones, can sometimes not be very relevant to families with a child with a disability. There's a scale called the QI disability that was developed in Australia that's actually very good at looking at the family burden of having a disability. And then another scale we use a lot is the parenting stress index. And then there's a scale that was coming out of UPenn but isn't fully validated yet that is a parental accommodations measure that measures, you know, what we noticed is that families would rate a behavior scale. They would say, oh, if I do these 8 things, then behavior is okay. And so I'm just going to say 0 for the patient doesn't have the behavior. But they had to do like 8 different things to make sure that behavior wouldn't happen. And so what that thing measures is all the different accommodations parents have to make sure their kid can like go out in the world and tolerate it, for instance. So I think we are trying to measure the parental gain. Traditionally, the FDA hasn't been very interested in how much the parents are, in the parents' stress or quality of life. They really want it to focus on the patient. So that's never a primary thing, but we are trying to look at it.
Are you having any experience with wearable devices and anything there that you think might help us as we go forward?
We do. We use something called Mobility Lab, with sensors. You know, there are a lot of, and it's probably the future. I'm not sure they are fully ready for prime time because you get so much data that is sometimes it's easier just to look at the video without any quantitative, just the qualitative. You see that the movement is better. But the future is on digital, Stan, definitely.
Yeah, people keep asking about AI. And I think where AI is going to make the biggest difference is wearable devices that give us real-life information.
I think wearable devices are obviously very important and are being implemented. I think there's some things that we have to bring into consideration as what's feasible for a patient during a trial that's tolerable to a child with autism, and these are things that may limit them despite scientifically, of course, we say that those things will provide more quantitative measurement, but realistically putting on a bunch of leads or other devices on a child with significant sensory sensitivities is a challenge. Even safety measures like EKG leads and EEG leads, which we obtain to have additional quantitative assessments and qualitative biomarker analyses. These are things that we're doing, for me, under some sedation, because even putting those leads on is a challenge. So I think that, yes, those are things important when we can, and we of course want to, but also keeping in mind what's tolerable for a patient. You know, because if it's not meaningful data, then we can't really use it either if it's just snippets that they rip off or whatever. You know, these are real life considerations.
We have, you know, Olivia, we have a solution for that we started using, and that's what AI will do. We don't need devices anymore. We are using 2 cameras, or a stereo camera.
Oh yeah, we could do cameras too.
And the AI identifies the limbs without putting sensors. You can do the analysis of movement in freely moving people with no sensors. And the results are spectacular also.
We can incorporate more of that too.
Well, I was going to say, we, you know, doing our evaluations, we have, you know, it depends on the day of the week, right? Did you take an overnight red eye, and did she sleep well the night before, and did she poop? And all these other variables that play a role in like our one outcome measure. And so in our ATN1, which is the DERPA clinical N-of-1, I do an ataxia rating scale called the SARA, which is great, and it has been helpful. However, we have a group up at Mass General, Dr. Anupta Gupta, who is using wearable devices, and we've teamed up with him so that he puts it on 2 weeks before his dosing, 2 weeks after his dosing, right in the middle of the dosing. And you're doing it for not just that one time point at that one day, you're really seeing like how is he living and how is that wearable device. But it definitely can be a challenge when it comes to like wearing these devices. So I think using it all together, video, we've done video as well. We did video during COVID. We were getting videos of gait analysis where we did pose estimation, and that was how we captured data virtually.
It's fantastic.
We've also been using, we use Mobility Lab for our Niemann Pick patients, as well as the Neurocom, which is this balance meter that PT has that's actually accepted for trials of physical therapy and stuff. So we use those. Those require the patients to be a little higher functioning than many of our developmental patients, and they just can't cooperate. Like if you tell them, you know, walk down there and back, they don't, you know, they turn this way and that way, and then the measures become uninterpretable. So we, in one of the early trials in Angelman syndrome, they used one of these wearables that you put on the wrist. It looked like a Fitbit, and some of the Angelman patients ate it, so that wasn't good. But more recently, we've been using the Actimyo, which is now the Scythe, and it's actually approved by the EMA as a standardized motor outcome measure, and it's on the ankle, so the patients with developmental disabilities can put it on. We have 2 n-Lorem patients that we're looking at that with, just to see if we see any change. It also has a lot of outputs, you know, and so figuring out which is the right one to measure can be difficult. But in Angelman, what we found was just measuring how much they walk in a day. Something very simple was showing us some change. So I think these things, we have to learn how they work and in who, and then they're going to come along.
Yeah, and you know, just before, I don't want this to be lost on the audience. We're talking about treating autonomic dysfunction. Never before in the history of ASODM, which I know well, have we ever shown that we could affect autonomic function. And we are demonstrating that for the first time in n-Lorem trials. Same way with pain. we had never been able to demonstrate meaningful reduction in pain until actually Susanna. And so the new Apple Watch, which is measuring blood pressure, I guess using Doppler, I'm not sure what they're doing, but to be able to ask autonomic function in a real time. You know, I was asking you, what about pupillary light reflex? I mean, who remembers pupillary light reflex but me and you, right? Yeah, okay. Yeah. You know, to be able to, if there were things that, you know, the tech side of things could do for us, I think it's in wearable devices that are wearable. Mm-hmm. You know, ankle bracelets sort of remind me of house arrest, but okay, it's better. It's better than a lot of things, I guess. Yes. We got another question.
Good morning. My name is Leora Schiff, and I'm fascinated by how quickly things are evolving in this space. Miraculous is a good word and should be used a lot, but it strikes me that the evolution of clinical testing, the kinds of outcomes that you're evolving are new, they're not well understood, and I'm wondering to what extent payers are being brought along your journey. Because at the end of the day, we want these to be reimbursed and accessible treatments. And it strikes me that in anticipation of bringing these treatments to fruition, there should be ongoing education of the payer community. And I'm wondering to what extent that's happening.
We have actually been billing insurance for all of our N-of-1 trials, for all the medical parts of it. For these exploratory outcomes, obviously there's no code, so we don't bill insurance. We have these things at our institution, and we just apply them to the trial. But for labs and infusions and clinic visits, we do bill insurance. We tell insurance up front what we're doing, and we explain. Sometimes I have to get on and do a peer-to-peer with insurance, and during that time I have the opportunity to educate at least the person I'm on the phone with. But I think that my experience has been that in a lot of cases, when I'm dealing with that particular patient with that particular rare disease and their insurance, they've been pretty understanding about it. But I agree that across all insurances, and I may have just been lucky so far, but I think across all insurances we need more education about what is N-of-1. But actually, the conversations with insurance have not, in some cases, been as challenging as the conversations with my institution, because sometimes even after the insurance approves it, the institution is complaining about your billing insurance for this investigational thing. And I think there's a lot of need for education of institutions, actually. Yeah.
And how do you handle that? To us, they don't allow us to bill the insurance because it's done at the research center. We would like to bill insurance.
Well, we do it at our research center, which I was originally in charge of building, and I made sure it would be both a research, that you would be able to see both clinic patients and research patients, with the idea that the future of neurology is going to be like oncology, where many of our patients are going to be both clinic patients and research patients as new treatments are evolving. So we have status in both areas.
But how do you do it? That's the way it should be. But you don't get pushback.
Oh, I get pushback, but then I just argue. But then I just argue with them.
You need to take a lesson in meanness from Liz.
Absolutely. Yes, I want to learn. Yes.
Rigidity, persistence. I am a marathoner.
See these bands?
She's resilient.
Very good. I think that this is a very important point.
Yeah.
Right?
I never wanted to learn about insurance, and I think it's a tragedy that physicians spend so much time on administrative nonsense instead of taking care of patients, but okay. So over the last little bit, I've invested in learning about insurance, and everything I've learned fills me with despair. But and I've talked to these experts, and the first thing they tell me is that all the really difficult patients are reinsured. They're not insured by the primary insurers, and they tell me. Then I ask, well, who's the reinsurer? And everybody says AIG. And then I say, AIG, oh, I remember Too Big to Fail. Oh yeah, that's AIG. And I ask, well, who do I talk to at AIG? And no one knows. I mean, there is no one to talk to. But maybe I'm just, maybe I'm so naive and I shouldn't be so desperate, but tell me I should feel better.
There's a couple different models. I do implore the community, because I do know that there are people in this audience who have gone to the hill to fight for this. Importantly, n-Lorem said you don't even have to pay for the drug, right? Like, you don't have to pay for the drug. You have to pay for the administration. We actually got a denial for one of my patients for the anesthesiologist bill, and they were like, the drug's not, and when I read it, and I get denial bills every day for like Ritalin. So, for this, it's like, are you kidding me? But so I read the denial, and it said, well, the medication was not FDA approved. I said, but I'm not asking you to pay for the medication. I'm asking for you to pay for the anesthesia to put them to sleep so I can give this medication. So I do think it's about educating, I think banding together with the community to say, like, we're not even necessarily asking you insurers to pay for the research behind this. The oncology groups are worlds ahead. Let's learn from them and what's working for them. And we'll push forward on the other side.
You do the spinal tap at the research center or in a regular?
So at our institution, every institution is different, right? Yeah. So institutions need to be flexible and figure it out. And the people who are doing the billing are different. We do ours not necessarily in the research part, we do it in the hospital side, but they cross over. And some of the bills are standard of care through insurance, and some of them are through research. So, we at our institution, we can pick and choose what we're going to bill to insurance versus what we're going to bill. It's not black or white, all have to go to research, all have to go to insurance.
That's true for us too.
Yeah.
And we are the wedge that I hope will drive more fundamental changes over time. And the answer here is to find the equivalent of standard of care or commercial, and there's work going on to do that. The first step is to demonstrate there's a reason to do it, but. I think for folks in the audience here, what you're hearing, to my mind, is horrible. That people have to spend so much time dealing with the system rather than dealing with the patient. Yeah. And that's all of our problems, folks. It's not just the people on the stage here. Everybody's affected by the system. And every minute that is invested in dealing with the system is a minute that doesn't get invested in the patient and in the research and in doing what is right. And it makes me crazy. I don't know how you guys stand it. It just would drive me batty.
I mean, I think getting...
I would go kill... never mind.
I'll
I'm not violent. I'm not really violent.
No, but I think getting back to the question, though, of really informing payers and things like that, of awareness of what's happening, I think is important, just because things are happening at a rate that's different from regular, clinical or investigational studies, and that's the difference, I think. And there's certainly, aspects that are not billable at all in terms of investigational drug services and other measures that are all research measures. And so I think these things come into play in a significant way if we're talking about currently investigational therapeutics towards a pathway to actual clinical treatment. At some point, that's going to have to evolve, whether we're fully billing to research, research under grants versus some to insurance, or at some point to insurance, but I think these are things that need to be discussed and brought up because it's happening at a rate that's faster than typical.
There's no numbers, but we guess that a Nano-rare patient costs the healthcare system about $3 million for a life. And we can treat if we only treat one patient with an ASO for $1 million, if we treat 5 patients, it's 200,000, and so on and so on. So I thought naturally the insurers would be our natural allies. They're not incented to reduce costs. That's the other thing I've learned, and somehow all that has to change. We have to find a way to make it economically in everybody's interest to get nano-rare patients treated, because it is in everyone's economic interest to have them treated. Sorry, I don't want to get on the soapbox here, but...
No, my question is relevant to this topic. Just as a parent and a family member of somebody who's getting treated, we appreciate so much how much advocacy comes from our doctors to our insurance companies and how much time you spend with that. But what Dr. Kravis said, I didn't realize is an issue about often it being the institution that's more difficult to actually deal with insurance. And my question is there anything that patients can do within the system or families can do within the institutional systems to make that faster, advocate for that to happen in a more efficient way?
I think that's institution dependent as well, but I think sometimes navigating institution is challenging, and sometimes it's helpful to be direct from the patient, but more often going through your research team is more helpful in navigating that together in a cohesive voice, I think.
Well, one wonders, and I don't have the answer. Is it better? This is an example, right? What you're doing. You're at Columbia, I'm at NYU. We're both in the same city, dealing with the same insurances. My institution says you cannot bill, period. You have to bring the money and goes to the research center, so we bring money from another sources. We would love to be able to bill, let's say, for anesthesia, to bill insurance. If the way to do this is to all get together and negotiate it together with insurance, or maybe not. Maybe if you have a good deal, why will I say, hey, you see where I'm going? I don't know if this is better to do it as a group or each one. Meaning, why would I screw your great arrangement? You know,
I mean, I'm going to be honest. A year ago, I wasn't telling anybody that I was doing this. Like, right? Because like you want. I know my partner. He's not in medicine. He says, ask for forgiveness later. Don't ask permission, right? But it's true, right? Like, it really depends on you want to work, and I really appreciate you putting all the other people that are supporting you on this, because it's not just me and my research team. It's the whole institution saying we're going to do the MRI on the same day as the LP, and that's a big thing for institutions to organize, a lot of them. And I think you don't want to mess it up. Like, I really don't want you to go home and your insurance to be like, hey, so I saw that n-Lorem, the Colloquium, and we're gonna have to talk about those bills, right? So like, I do think us as a whole have to think about how to push this forward. And maybe this is where we're learning from our colleagues in oncology to say, like, how do we shift this? Like, we need to be able to do this. I do think that there are situations where parents do have more push in the hospital. If a patient goes to patient services, they're going to get much further getting that MRI at 7 a.m. than I am as the doctor. So I think there's a role for both of us.
Yeah, I also think that patients can play a role, sometimes in philanthropy, although we don't ask patients to do that. And sometimes patients want to create community awareness, and they talk to our PR department, and I think sometimes that's also a very helpful way of the hospital saying, oh, this is what we're doing. It might also be a helpful way of getting other hospitals on board, because if one hospital has a show about doing something really novel and treating a patient, then other hospitals may want to compete and be in the world of advancements. So these are things that may or may not be helpful. But I agree with you. We have been billing under the radar for the patients that don't need anesthesia. They don't have any big bills. They just have an LP fee and a clinic fee and some blood work. And we have one patient we've been doing this with in an expanded access program for 12 years now, and the insurance has not figured out that we're doing anything. So we don't want to rock that boat for sure.
Don't tell anybody.
That's right. I'm not telling who it is.
Oh, we want to cheat as much as possible. No, thanks, Liz. It's really helpful.
Stan, we have one more question over here. In the audience, maybe
Okay.
Hey, sorry guys, sorry I didn't even cheat. It's kind of a two-part question, but I think first part on the conversation we're having right now, I think the conversation you all are having on stage is, I think, also a national and political conversation that's happening right now about insurance. I almost think if this conversation went out on social media, it would almost become viral because I think the world is having this conversation, but maybe not quite so blatantly with experts. So I would ask, when we talk about the community and what the community can do, it almost feels like pressuring other hospitals to kind of maybe take the approach of what Rush is doing for their own institutions. It seems like something that would resonate quite well. I'm wondering what the best way for the community to maybe amplify that potential conversation out in the world, or make other hospitals aware that Rush is doing that, whether it's a show like you mentioned, Dr. Kravis. And then the second question I had was, what is the FDA sort of, or like the long-term approach, knowing that with nano-rare diseases, we won't have the pool to necessarily do a traditional FDA study where they would approve medication and be taken on by insurance. So past the 2-year mark, what does it look like for getting something approved that insurance would start covering these ASOs going forward for patients?
Well, I'll talk about the FDA. I think when I spoke with the senior people at the FDA in 2019, the only absolute no I got was that there would never be a path to approval for an N-of-1 medicine. And I think as a result of the sort of effects that we're seeing, I see that changing. And there is a move now toward finding a path toward commercial approval for N-of-1 medicines. I don't claim to know where that will go or how it will proceed or when it will happen, but just that shift, and it was actually the same person who said no to me who is now leading the charge toward approval. The very same person. I won't mention her name because she'd probably get mad at me if I did, and I don't want to do that. But so there's progress. And I think the way to motivate that progress is exactly what we're doing, which is to demonstrate that we can do this repeatedly, safely, and see benefit. And therefore, there must be a path created. Long term, we have to change the economic model as well, so there are a lot of things to work out. And my view of doing anything impossible is you do it one step at a time. And we've taken the first step. Others are now beginning to take the second step. I don't know where the third step will be, and I don't know when it will be, but I want to drive it that way. And I think that's all that we're doing here. But I don't want to end this trapped in the administrative intricacies of just how do we pay for this, how do we do this. I really want to make sure that we end this the way we should end it, which is what you've heard is we have to discard everything that we know about developmental delays, rethink it all because of the work that's happening with ASOs here at n-Lorem, to a large extent in Angelman and other diseases. And so it's a new day. And what wasn't possible yesterday is possible today, and what will be possible tomorrow, I don't know. That's the message.
Everything is drug effect size. All this thing of approval is about effect size. The biggest problem, I believe, and I'm going to exaggerate a little bit, is not the regulatory problems. The biggest problem is our drugs. Now, these ASOs are incredibly powerful, so that's what's going to make a difference. If you have a big effect size, you need 10 patients to approve a drug. I mean, it's all about calculating the statistical difference. And if a drug is really powerful, you need 12 patients or 10. The trials of SMA were 21 patients, right? So it's N of 1 repeatedly. And when you do many N of 1s, it's not N of 1 anymore, it's N of many.
Yeah. Well, knowledge is power. As I said yesterday, we reside on a scaffold of knowledge that has been built over centuries, and we're looking at miracles. And let's keep at it. With that, thanks everybody.